minutes, what we'll go through. One of the big questions that everybody has is, what is Medicare? What is the government trying to do with MACRA? What's happening? What is that? I'll try to go through some background information for you on that, get into a little bit of the details, but we can't be exhaustive in 45 to 50 minutes. Also try to answer the question, what in the world is an HCC code? And if I don't know what that is, why should I care? That's something that is being used today in some groups. Some of you may be very, very familiar with that. For others of you, it may be new, so we'll kind of walk through that, and then I'll show you how that HCC coding, how that risk-adjusted coding is going to impact your MIPS score, which is obviously the new program that the government is rolling out that replaces meaningful use and e-prescribing and PQRS and the value-based modifier. We're going to talk a little bit about MIPS, how risk adjustment impacts MIPS as well. Because what that means for us is that diagnosis coding is about to change again, right? We've been through, obviously, a big change. It's hard to believe it was only 9 months ago that we made the switch from ICD-9 to ICD-10. So we're about to go through 2 more changes to diagnosis codings that are coming up that many people aren't paying as much attention to as they should. So we're going to talk through that. I'll try to share with you how some of our clients are handling that, people who are already in this world, and then obviously I'll leave time for questions and answers at the end. So that's what I hope to accomplish in the next 45, 50 minutes. I'm going to go ahead and launch our first poll question so that you can take a look at this. And what we're looking at here is, where is your practice as it relates to MIPS? So if you'll just pick one of those 4 choices and let us know kind of where you are, that'll give us a good barometer to let everybody see kind of where they stand, where they're starting from, and obviously any of those are acceptable answers. It's just a status update of where you are right now. So what I really want to talk about, and I'll flip you back to the slides as soon as everybody answers the poll question. What we want to talk about is, what is Medicare trying to do with MACRA? What are their goals? What are they hoping to accomplish? Why are we doing all of this? Obviously one of the things that the government is trying to do is bend the cost curve down. Everybody knows that we have thousands of new Medicare beneficiaries each day. It's 10,000 a day right now as the baby boomer demographic ages into Medicare. And so what the government is trying to do is the triple aim, right? You hear this a lot from Medicare. You hear this a lot from politicians. They're trying to deliver better care and lower costs and improved patient experience. And a lot of what's happening towards that triple aim is Medicare, the federal government, is taking risk off of themselves and pushing that down to patients and pushing that on to providers. We've seen this, I'm sure all of you have seen this probably in your personal life. We've seen this certainly with our company here, is health insurance, whether it's Medicare or whether it's private insurance, the premiums are higher, the deductibles are higher, more of that risk is being borne by the patients. I'm sure that you guys have seen that trying to collect from patients as well. That makes that more difficult in the provider community. But what it's doing is it's trying to get those patients more involved in their own care, right? That's what they're trying to do. They're also pushing some of that risk on to physicians. They're trying to measure quality. They're trying to measure costs and resource use. And one of the big things that happens there is the risk adjustment. And the reason why risk adjustment is so important, it sounds so simple, but what Medicare has been trying to do is says, we've got to measure cost, we've got to start paying for quality, right? Trying to transition away from that fee-for-service world. And the pushback from the provider community that is very legitimate is doctors say, you don't understand, because my patients are sicker than your patients. You don't understand, my patients are sicker than the Medicare average patient. That's why it's so difficult to measure quality and so difficult to measure cost and to shift our reimbursement to that model. And CMS has really gotten to the point that they're saying, okay, prove it. We'll handle risk adjustment. We will try to scale our quality and cost measures to the sickness of your patients, but I need you to prove it. They're taking the data that we've been supplying them for years from a claim perspective, and they're starting to use that to measure patient acuity. So we can look at some of the things that Medicare's been doing in the past to see how that's going to work under MIPS. And this is really where we start to get to the HCC perspective. HCCs are hierarchical condition categories. They have been around now for 12 years. They were created in 2004, and they were originally created for Medicare Advantage plans. They were used to measure patient acuity. These Medicare Advantage plans were taking on upside and downside risk, similar to what you see in ACOs. And they said it's not fair to be paid the same amount capitated for every single patient. So they were paid more for their sicker patients and less for their healthier patients. Now that's risk-based adjustment. That's what they were doing. Now that use has been expanded. It's now currently used, obviously, still for the Medicare Advantage plans, but it's also used for hospital value-based purchasing. It's used in some of the ACOs, patient-centered medical homes. It's used also in risk-adjusted transfer payments to different health insurers under the exchange plans, so that the plans who had sicker patients sign up get a transfer payments from the plans that get the healthier patients sign up. They're using that for the risk-adjusted transfer payments under the Affordable Care Act. And the commercial payers have also been adopting this in some of their risk-adjusted plans. So I'm going to ask the second poll question real quick, and that is, are you, in your practice today, do you have any risk-adjusted contracts with your commercial carriers? If you don't know, it's okay. We've got an option for not sure, but just let us know. We've seen that in some practices, particularly in some larger multi-specialty practices in large cities, where their large payers have started to come ask them this. But many of you probably haven't seen this yet, and that's quite all right. We're just trying to get a barometer for where everybody is. That'll be helpful for us. And again, we'll share those results. Right now, it looks like nearly half of you have not. Only 10% for sure have a risk-adjusted contract with a commercial payer. So that's what HCC codes are used for. They're used to measure that patient acuity. Let me walk you through just kind of some of the math behind how the patient acuity works, how the HCC score works. All right. What we see when we look at HCC coding, it is basically the demographics plus the diagnoses equals the HCC score. The demographics plus the diagnosis equals the HCC score. So let me walk through the demographics real quick. Very simple. Age is a component. Older patients are typically sicker, so they have a higher value under the demographic piece. Gender comes into play. You obviously see that with it's particularly high. The biggest area where you see a difference between male and female is obviously during those childbearing years, because that's, as far as we know, men can't have children yet. So the women are going to have higher healthcare expenditures during those years. Eligibility status comes into play. Is a patient dual eligible, meaning they've aged into Medicare, but they are also poor, so they're Medicaid eligible as well, or if they are disabled, if they are living in a nursing home, some of those factors will come into play for the HCC score as well, trying to measure some of those socioeconomic factors that have an impact on future healthcare expenses as well. So that's really the demographic piece. That is what it is. There's not much you can do to change that. The other part is the diagnosis coding. And so for Medicare Advantage plans, what they do is they take the diagnosis codes for a particular patient for the past 12 months, whether that's ICD-9 or ICD-10. Some of those have an HCC code that corresponds to it. You don't have to do any HCC coding. The payer is really doing all of that for you. But they take those diagnosis codes from the past 12 months, and they use that to have some significant predictive power to look at what the healthcare expenses for that particular patient will be over the next 12 months. And that's how they come up with the capitated rates for the Medicare Advantage plan. they take the HCC score, they multiply it times the average Medicare cost per beneficiary. Right now, that's just over $9,000 for the majority of the country. There are some regional effects to that as well, and that gives you the projected Medicare cost for that particular patient. So the higher the HCC score, the sicker the patient. The sicker the patient, the higher projected Medicare expenditure, the higher capitated amount CMS will pay the Medicare Advantage plan. All right, let me show you an example, because I think it helps sometimes to help wrap your head around what's going on here with the HCC codes. So if you've got a patient who's a 76-year-old female who is dual eligible, what you have is a patient with an HCC score of 0.593. Just for a point of reference, the average Medicare patient is 1.0. The average Medicare patient is 1.0 HCC score. That's always true. So you take that HCC score, you multiply it times the average cost per Medicare beneficiary, and the Medicare Advantage plan gets $5,366 to care for that patient. If they're able to deliver better patient care and they're able to keep costs down, they will make money on that patient. If the patient has some diabetes that's out of control, we didn't code it, right, that you're going to have to keep up with over the year, the Medicare Advantage plan is going to lose money on that patient. And that's why, one of the reasons why your coding is so important. If you look at the exact same patient, but you say we actually coded the diabetes, right, we get HCC value for that, 0.118, and so you can see that patient's HCC score is now closer to the average Medicare beneficiary, and the dollars that go along with that patient are much higher as well. If you also code the vascular disease and the congestive heart failure and the disease, there's a disease interaction if you have congestive heart failure and diabetes. There are some additional points that go along with that under HCC. And you can see the score is now 1.81, and the Medicare projected cost for that particular patient and what's paid to the Medicare Advantage plan is $11,000 higher than if they had not coded any of those HCC diagnosis codes. So hopefully that gives you, it starts to give you a little bit of an idea. We're going to get into more detail of that, but I wanted to show you a risk-adjusted coding example on the front end so we can start to have that in your mind as we start to walk through what's happening with MACRA, what's happening with MIPS. Okay? So that's just a small foretaste of what's happening with risk-adjusted coding. So what's happening with MACRA? You kind of have this out with the old, in with the new. We said goodbye to the SGR cut. You remember when this was passed last spring? That was one of the things that everybody was excited about. We don't have this 21% SGR cut hanging over our heads again, and that's very, very good news. People got really excited that they saw this means meaningful use is going away, and PQRS is going away, and the value-based modifier is going away. Unfortunately, a lot of the new program is just repackaging of the old program. Right? There are two tracks that were created under MACRA, MIPS, and the alternate payment model. The best way I've heard this described is everybody is going to fall under the MIPS category and is going to be measured that way. There will be some who are able to participate in the alternate payment model route. If you are going to be eligible for the alternate payment model route, you probably know it already. Because there are some pretty significant requirements to meet that. Even if you are pursuing the alternate payment model route, you will still collect the data for your MIPS score so that if you do not qualify for APM, you get put back into MIPS. But everybody will automatically be participating in MIPS, right? Your score may be 0 if you're not doing anything for it, but you will be enrolled in that program through Medicare. So the way that MIPS works, so let me spend some time on that. The way that MIPS works, it's got these 4 different categories: advancing care information, clinical practice improvement activities, quality, and resource use. Let me spend just 30 seconds on each of them. Advancing care information. This is the section that really replaces meaningful use. So yes, the meaningful use term went away, but advancing care information is very, very similar. But the requirements are going to be a little bit different. It is a little bit easier, and it's not all or none. One of the things that people didn't like about the meaningful use program was if you missed the bar by just 1 point, you got nothing, right? You were ineligible for the incentive payment. And under MIPS, there is partial credit. There is partial credit. And the major requirement under advancing care information is that you're using a certified EHR that is eligible, or that is available and capable of sharing information, exchanging data, and that you are doing all of the things that you need to do under HIPAA. Clinical practice improvement activities. This is the smallest category from a weight perspective. There are 90 different choices that your practice can choose to implement, and you get points for each of those under MIPS. The two biggies is what Medicare cares about most, obviously, which is quality and resource use. Now, they call it resource use. If you wanted to call it cost, that would certainly be an acceptable synonym. That is what they're trying to measure there, and you can see those two categories combined are always 60% of your total score. 60% of your total score will be quality, right, which is very similar to PQRF, looking at some of those outcomes measures, looking at some of those process measures, and then resource use, which is cost. The good thing, bad thing about the cost measure, you don't have to submit any data for that. There are no registries or anything like that. Medicare is calculating that automatically based on your claims data. So they've been collecting this data for years, and they are now going to start to use that to grade your practice on how you're doing from a cost perspective, and then they're going to be comparing that to your peers. So you've got these 4 categories. You can get points in each. The total number of points will be graded from 0 on a scale from 0 to 100. Okay, so you will, in 2017, you will have those 4 categories, and they will total a score from 0 to 100. The 2017 MIPS score will be compared to your peers, right? So this is, think back to your college days. This is grading on a curve. It matters how the other people do. And then Medicare is going to determine and set a performance threshold. Nobody knows where this is going to be yet. It looks like Medicare does not know where this performance threshold will be yet. It will depend on how everybody does on their MIPS scores. If nobody does very well, the performance threshold will be set lower. If everybody does very well, the performance threshold will be done higher, right? So you're graded against your peers on that. And then you will have an adjustment to your fee-for-service reimbursement 2 years later. Right, so it's very similar to PQRF in that you get your score based on 2017. That's the measure year, and then the payment year is 2 years later, because the government's going to have to crunch a lot of data to figure out where everybody fits on this curve, what the performance threshold is, and then to make those adjustments. So the people that are above the performance threshold will receive a positive adjustment in their fee-for-service. The people that are below the performance threshold will receive a negative adjustment. The larger you are, the larger your distance between your score and the performance threshold, the larger your adjustment. So the people who are on the tails will have larger negative and positive adjustments. The people that are closer to the middle, closer to the performance threshold, will receive smaller adjustments. It is very unlikely that many people will receive a 0 adjustment, because you will have to be at the absolute middle of the pack in order to have a 0 adjustment. Most people will have at least a small negative or positive adjustment. One important thing to note is that the total adjustments will be revenue neutral to the government. The total adjustments are revenue neutral to the government. That means that the dollar amount of the negative adjustment will be equal to the dollar amount of the positive adjustment. And that's part of the reason that makes this so complicated and difficult to model, is you don't know how your peers will do, and you don't know what their total Medicare reimbursement is. So to figure out how big the pot is for the potential positive adjustment, you have to know what the negative adjustment is. Now, before anybody hyperventilates, let me put this a bit in perspective. If you look at an average practice in 2019, right, you're still going to be working in the fee-for-service world, and you're going to have the blue ring, the blue part of that ring is your commercial carrier, your non-Medicare fee-for-service reimbursement. The portion of the red ring is your Medicare fee-for-service reimbursement, and that assumes that 31% of your medical revenue comes from Medicare. Okay? Those other colors that are really hard to see, the purple, the blue, the orange, those are your MIPS adjustments. So it's a very, very small percentage of the total practice revenue, right? That's the good news. But I don't think we can take that to mean you don't have to pay attention to MIPS or you can ignore it because it's less than 1.5% of your total practice revenue, because of really two things. If you fast forward a couple of years, you can see that the maximum MIPS penalty goes from 4% of your Medicare fee-for-service to 9%. Medicare, the population is growing as well, right? 10,000 new Medicare enrollees each day. And the commercial carriers are moving in this direction as well. The commercial carriers want to move away from fee-for-service, and they're going to follow the government's lead on this, right? And so that means that change is coming, right? As much as we'd love to avoid it, we know that change is coming, and we need to be prepared for that. And the good news is there are some things that we can be doing to get out ahead of it, okay? There's some things that we can be doing to get out ahead of it. So let's kind of jump into some of the details and think about what the payers are doing with the claims data. What are they using that for? You know, right now, and really for the past 35 years, we've had encounter-centric coding or doctor-centric coding, right? And what I mean by that is you've got a face-to-face encounter with the patient. You're going to get paid for those CPT codes. You know, volume is what matters most, right? You're getting paid on your productivity. And the diagnosis code is important insofar that you got a diagnosis code that supports the CPT code that makes it medically necessary that payer will accept. That was true in ICD-9, and that's true in ICD-10. Now, if you remember, one of the things that everybody was worried about during that transition from ICD-9 to ICD-10, from 16,000 codes to 69,000 codes, was that denials are going to skyrocket. The payers want more specific diagnosis codes, and they're going to start denying claims. Denials were going to double and triple with the prediction from Medicare. And you look at the data about what's happened, and denials have not increased at all. And that's because of the grace period that Medicare announced last summer that says we're not going to deny for lack of specificity. We won't penalize you under PQRS or under the value-based modifier for unspecified codes before October 1st, 2016. So that grace period is expiring. And that's the first big change on the horizon from a diagnosis coding perspective that says we are going to start to have to be more specific on our diagnosis coding. Now, we have worked with many of you on that. You probably know the unspecified rate, the national average, is over 31%. The white plume client average is just over 12%. So our clients, you are doing a great job with this. Many of you have taken steps to get that even lower in your practice. You're prepared for the change that is coming on October 1st. And if you still need help with that, let us know. There's still time to make some changes to that and get your unspecified rate down. But the second change that's coming is that Medicare is going to use the claim data for risk adjustment under MIPS. And that means that our diagnosis coding is not just about getting the CPT code paid. That's still important, and we want to do an excellent job with that. but it's going to be used for risk adjustment, setting the bar for how you're going to do under MIPS. And that means your diagnosis coding has a 2-year tail on it. It's not just a 30-day cycle, right? If you make a mistake with your diagnosis coding today, you get a denial, and you can fix the denied claim, and yes, it takes some time, and yes, it takes some staff, but it's a relatively painless process. Going forward, our diagnosis coding is going to be much more important, both for fee-for-service and getting the claim paid when Medicare and the other commercial carriers start to require increased specificity after October 1st, but it's also going to matter as we begin being measured under MIPS starting January 1 of 2017. So diagnosis coding is going to be much, much more important than it ever has been in the past. This is a big shift for the provider community. I think many of you are very well positioned to handle this. If you're not doing a good job of it already, there are some steps that you can take to be prepared for this without requiring a lot of additional effort from your. But we want to make sure that you're thinking about this, because in 2017, your diagnosis coding is going to matter for your 2017 fee-for-service. It's going to impact your 2018 HCC scores, which is going to impact your 2019 MIPS, both for resource use and for the quality measures. So we want to make sure that we're doing that well. Remember, that's what the government wants to measure. They are focused on resource use and cost, and they're going to allow you to do risk adjustment under that. So you need to make sure that you're accurately reflecting how sick your patients are. I like examples. I think they're helpful. Let me walk through an example for you. You know, right now, part of the frustration is Medicare thinks your patients are much healthier than you think your patients are, right? You think your patients are pretty sick. Every doctor that you talk to says, my patients are sicker than average, which is obviously statistically impossible, right? Everybody thinks their patients are sick and sicker than everybody else thinks they are. And how do you explain the gap between those two? How do you explain the difference between what Medicare thinks about your patients and what you think about your patients? It's what you code, how you code those diagnoses. And that's why I'm trying to really hammer home the point that what you code really, really matters. Again, it really, really matters in the current year for fee-for-service as the payers start to crack down on those unspecified codes. It will really matter for next year, looking at your HCC score for your patient population. How sick are your patients? What does your average patient look like? And then when you start to have the MIPS adjustments 2 years out, right? What you coded in 2017 is going to impact whether you had that positive adjustment or negative adjustment under MIPS, under these two big categories. Okay, so let me give you an example, right? Let's look at a patient today, right? The exact same 3 patients. They all need total knee replacements. And today, 27447, I get paid for that CPT code as long as I have a diagnosis code that makes it medically necessary, right? That unspecified osteoarthritis is an unspecified knee. Now, many of you have been to our other webinars and know we don't want you to code it that way, because when you do, that patient looks relatively healthy, right? Now, let's look at the exact similar patient, needs a total knee replacement, but this time we code primary osteoarthritis of the left knee and morbid obesity, right? They're carrying too much weight on not a big enough frame. That's part of the reason that caused the problem in the knee to begin with. Medicare sees that patient as much sicker than the first patient, but still not a complete, accurate depiction of how sick that patient really is. What if I code primary osteoarthritis of the left knee, morbid obesity, but also type 2 diabetes with polyneuropathy? Now I have an accurate picture of that patient's acuity. Now again, today, under fee-for-service, that claim is probably getting paid the exact same way today. There is no difference between those three scenarios. And that's why most people are only doing number one, maybe doing number two. But most people are not doing number three. But in the fourth quarter, right, that's where we're going to start to see the difference between number one and number two. Even if you only coded primary osteoarthritis of the left knee, right, we're being more specific. We're avoiding that denial from when Medicare starts to crack down on those unspecified codes. But what about my HCC code? What about my risk adjustment? Well, you can see the HCC code for those three identical patients is very, very different depending on how I did my coding, right? And obviously the adjustment that they would make for the average Medicare expenses for those patients, that's the adjustment above or below average. So this is why I say that coding matters much, much more than it ever has before. So just another quick poll real quick, trying to understand, you know, are you tracking, are you monitoring HCC codes in your practice today? Right? Is that something that your revenue cycle staff, your coding staff, your CFO, your doctors, you have anybody that's tracking that, paying attention to that today? Again, it looks like for most people the answer is no. That's over 60% right now that are saying no to that. That's okay. Again, what we want to do today is give you some education and start this process, because what we hear from a lot of doctors is, I don't want to do this. This is just one more thing for me to do. I'm not really interested in that, right? Let me give you, I got this from a Primera Blue Cross Blue Shield presentation that they did for some of their physicians last year. I thought it was perfect. I couldn't make it any better, so I wanted to borrow it and use it today. And the doctor says, I just want to take care of my patients. This is not going to help patient care. This is only busy work. I've been doing ICD-10 and meaningful use. Now you want me to do HCC coding? What is that? Look, I only get paid for CPT codes, right? I can hear our doctors saying that, you know, as I read through this slide, right? And that's a legitimate, that is a legitimate request, right? The good news is this is not asking you to change to a whole new code set, to transition like you did from 9 to 10. HCC codes are something that are calculated on the back end by the payers, right? They crosswalk automatically from ICD-10 to HCC coding, right? And so why is it important for us to pay attention to this? Why is it important to accurately code comorbidities, like for that total knee patient? Why do I code that they have diabetes with complications? Why do I code that they are morbidly obese? Because I want to get my accurate fee-for-service reimbursement, right? I've got to make sure that I do that, right, as the payers start to deny for those unspecified codes. But I also want to make sure that I'm showing how sick my patients are, that I'm communicating that appropriately to my payers, right? Because they're going to use that for risk adjustment. Both the commercial carriers and Medicare are using that for risk adjustment. Under MIPS, that gets used for the resource use and quality measures, right? So if I'm not showing how sick my patients are, the hurdle for resource use under MIPS is going to be set artificially high. The hurdle for quality under MIPS is going to be set artificially high. And that's not fair. That is hamstringing me from the very beginning. That is putting me at a disadvantage compared to my peers if I'm not accurately reflecting how sick my patients are. Right? The other thing that the government wants to do with this data is they want to publish it. They want to start rating physicians on cost, on quality measures, and publishing that on the Physicians Compare website. Right? Even if you said, I'm not participating at all, I'm not going to do any of this, I don't want my patients, my commercial patients, Googling my doctors, going to the Physicians Compare website, and seeing that they are low quality and high cost. particularly when it's not true, right? It's important to make sure that you accurately reflect the patient acuity of your patients so that you accurately show the excellent patient care that your doctors deliver. That's very, very important. And that's something that we're going to see coming over the next few years. And the commercial payers are moving in this direction as well. They want to move towards risk-adjusted contracts. Some of you have seen that already. Some of you are seeing that in your practices today. More of you will see that in the future, right? Commercial carriers typically follow Medicare's lead in this. And even if your payers are slow to do that, having this information and this data available in your practice is very, very valuable. Very, very valuable when you're negotiating with your payers to make that more of a. Think about it this way, our total knee example, there are two big payers in your market, Blue Cross and Aetna. Blue Cross is coming to you and saying, hey, we want some volume discounting. This doctor is doing 200 total knees for our patients a year. And they're putting some pressure on you there. Wouldn't it be nice to be able to go back and say, well, I hear what you're saying, but your patients are much, much sicker than my Aetna patients. If anything, you should be paying me a premium because I'm treating your sicker patients. Their HCC scores are 40% higher than my Aetna patients. And those comorbidities mean they're more complex cases, they're more likely to be readmitted, they're more likely to have complications post-op that we're going to have to deal with. We really can't give you that volume discount. We really need to be paid a premium for dealing with these patients. Your insurance carriers know this data. You are supplying that to them every single day. We need to take advantage of that and know so that you know what's happening and make that more of a level playing field when you're negotiating with your payers. Now, one of the questions that I get, particularly from specialists, is, these comorbidities are really primary care stuff that I'm not really treating. Let me share a little bit of coding guidance with you that comes from Medicare. I've got the link here for you if you want to go read the rest of it as well. But basically, any condition that exists at the time of the visit that will affect treatment or management or complicate it, as long as it's documented, you can code it. And that includes chronic ongoing conditions, which are where you get a lot of those HCC codes. It also includes the status conditions, the Z codes, under the ICD-10 code set. So the general principle still holds. You absolutely have to have it documented. But for many practices, what we hear is our physicians do a decent job of putting this in the documentation. We just don't code it, right? That's kind of the missing part, all right? So let me remind you, as you're thinking about this, under MIPS, you are going to be compared to your peers. It's not an absolute standard. It reminds me of the joke, right, of the two friends in the woods, right? They come across a bear, the bear starts chasing him, and the friends start running away. One of them stops to change out of his hiking boots to put on his tennis shoes. His buddy looks at him and says, "You're crazy, you can't outrun a bear." To which he replied, "I don't have to outrun the bear, I just have to outrun you." Right? You're trying to outrun the bear. You're being measured against your peers, okay? And that means that many of your peers are not paying attention to this yet. If you can get out ahead of them on that, that'll give you a jump start, at least for the first year, probably for the first two, under your MIPS scores, right? So I think it might be helpful to understand how some of your peers are doing when you look at this. So I'm going to share a little bit of data with you, but before we wrap up and get to the Q&A. We looked at HCC coding by specialty. Now this is just looking at the diagnosis portion of HCC. It's not looking at the demographics. And it's saying, what was the average HCC value per diagnosis code? Right? So you could have a patient that has multiple diagnosis codes. This is looking at HCC per diagnosis. And obviously what you see makes a lot of sense. Some of the difficult specialties, from chronic diseases, but also acute diseases are up at the top. Oncology, if you have a cancer diagnosis, that's obviously going to impact the expected Medicare expenses for that patient for the next 12 months. Nephrology is high. Then you start to get into some of the primary care practices, and then at the bottom you have some of the specialists, right? Remember that the pediatrician is not being compared to the oncologist. The pediatrician is being compared to other pediatricians. So you see a wide variety in the average HCC per diagnosis code across specialties. But let me also do this, and let's look within a specialty. Let's look within orthopedics, for example. 30 orthopedic practices, the average for each practice was 0.016, but you can see that some at the top of this list are doing twice as well, while some at the bottom are doing twice as poor than the average. That means there's a 4x difference between practices 29 and 30 and practices 1 and 2. They're all orthopedic surgeons. We're holding constant for demographic differences. So does that mean that practice 1 and 2, their patients are 4 times sicker than practice 29 and 30? Probably not. They're seeing very similar patients. They're using very similar diagnosis codes. What it means is some of those practices are doing a better job of capturing those comorbidities than others. The difference is not in the care that they provide. The difference is in how they code. Let's look within an orthopedic practice, right? Let's look within practice number 3, for example. The average for that practice is 0.026. But you can see that some of these providers at the top are 7 times the practice average. And some of the practices at the bottom are 1/3 of the practice average, right? Is there really a 20x difference between those two? Or is it really about how they're doing their coding? And so I bring this up because I know many people are probably not capturing this information today. You know, we talked about this. You probably have a wide difference within your practice. But let me launch this last poll here to really ask you, which of the following best describes the majority of your physicians? I know you may have some outliers that do a really good job or that do a really bad job, but what do you think describes the majority of your physicians? How are they doing on this today? Do they never document it? Do they rarely document it? Do they usually document, or do they usually document and code it? Right? And I think we'll have answers all over the board on that. It looks like the majority of people are actually doing a decent job in documenting it, right? We're probably right now close to 95+% of you are saying that your doctors do a good job of documenting the comorbidities, right? But as far as the people that usually code it, that's closer to 20%. And you know, that's similar to what we see here. You see some people that are really down at the bottom of the average, but the majority of them are doing at least somewhat of a decent job, but I think there's a lot of room for improvement there. And what that means is there's an opportunity for you to outperform your peers under the MIPS resource use just by coding accurately, just by improving that a little bit. Okay. Some people ask, I get this question a lot, so I'll share this with you. What are the top 10 HCC codes? What are used most frequently? And what is the weight for each of those diagnosis codes? So you can see at the top, obviously diabetes, COPD up at the top. Morbid obesity is a very high value when you look at the weight, 0.365. Do notice up at the top, type 2 diabetes without complications and type 2 diabetes with complications, you know, whether those complications are hyperglycemia or, you know, an ophthalmic manifestation, you know, any of those diagnoses that have a type 2 diabetes with complications is going to have a higher value than the type 2 diabetes without complications. So I share that with you just so you can start to wrap your mind around how are we doing from an HCC coding perspective. Are we prepared for the risk-based adjustment that's coming up? How is that going to impact my MIPS scores? How do I prepare for that? You know I went through a lot of information on that today, but what I'm going to do is I'll share this last poll question with you just for some follow-up information. So if you want a copy of the slides, you want the link to the recorded version of the webinar, or if you'd like an invitation to the follow-up webinar, feel free. You can check multiple boxes there. So if you want all three, check all three. We'll make sure that we get that follow-up information to you. We'll get that to you quickly. We kind of ran out of time for to talk through how some of our clients are tackling this today. We spent a lot of time on the education, so we'll jump more into that on the follow-up webinar, how our clients are handling that, people that have the risk-based adjustment contracts, what they're doing. If you're one of those people that is already using this, doing HCC coding, would love to hear what you feel like you've done well, what you haven't done well. That's always helpful for us. And again, a reminder for the questions panel, if you do have other questions that you haven't asked yet, go ahead and send those in because we're about to open up the floor and try to answer as many of those as we can. All right, one last slide before I get to the questions. Just takeaways. What do we hope to take away and leave today with? The first thing is I would say diagnosis coding is about to change again. Remember, we've got those changes ahead of us, right? And there are really two of them. And this means diagnosis coding is going to be much, much more important in the future than it ever has been in the past. Number one, the payers are about to crack down and require increased specificity on your diagnosis coding. Many of you, most of you, we probably already talked to about that. If you still have questions on that, if you need some help, if you need us to run that analysis again, let us know. We can help you with that. We're happy to do that. You can let Shelley know through the questions panel, and we'll make sure that we follow up with you on that. But the second change is what's coming for risk adjustment under MIPS for your quality measures, for your resource use measures, and it's going to be important to accurately code your comorbidities, to capture that so that you're accurately showing what your patient acuity scores are, right? So that you're accurately doing that. The good news is many of you have room for improvement, and there are some things that White Plume can do to help you with that, right? The quality and resource use scores under MIPS will be risk adjusted and will be measured against your peers. So even if you say, you know what, my doctors won't do any of this comorbidity coding, even if you're standing still, you're moving backwards. Because if your peers are doing that and you are not, it makes your patients look healthier than your peers, and so it makes your targets for resource use and quality measures under MIPS higher than those of your peers. So be careful about that. Remember, you are competing against your peers. That's good news, bad news. If you do start to make some of those improvements, I don't think it takes a lot to move the needle to make your practices better. There are certainly some tools that White Plume provides in ExcellaCapture and ExcellaSmart and ExcellaMobile that can try to make this as easy and painless for your doctors as possible. That is our goal. We do not want to turn your doctors into coders. We want them to be able to treat and take care of their patients and to be successful and to get paid fairly for what they do. There are also tools out there that we can provide that helps your billing and coding teams to review and correct places where you might have missed some of those HCC codes that you should have captured. All right? I hope that was helpful for you. I know that we went through a lot of information today. Please, just a quick reminder, another request, when you do log out from the meeting, you'll get a little reminder for the survey. It's only 4 questions. That feedback is super helpful for me. So if you don't mind spending 30 seconds to answer those questions, I would appreciate it. You'll also get a follow-up email after the webinar that reminds you and has a link to the survey as well. So if you don't mind answering those questions, I sure would appreciate it. Thanks again for your time. I really, really thank you and hope it was helpful for you.